So it's my pleasure to present our today's speaker, Alexandre Bejanin, who's the head of the Neuroimaging unit at the Sant Memory Center. And yeah, so Alex is a good friend of mine. We know each other for quite some years now, and one can say we grew up together scientifically. All these conferences we've always been to, and Alex did his PhD in France in Gael Chetelas lab, and then moved to San Francisco. He was at UCSF and at Berkeley, at both of these centers. Then had some time at stayed some time at Mayo at Keith Joseph's lab. So all the big names are on his list. And he's in his 5th year of his Miguel Servet grant. So you 5 years at the memory unit, or
7.
7 years at the memory, and 5 as a Miguel Servet researcher. Okay, so, and he will mainly present his work from these last 7 years, I guess.
Right.
Okay, looking forward to it.
Thank you very much, Michel, and thank you very much for the invitation. I'm very happy to be here today, very glad to discover finally the Fondation CIEN, and also this opportunity to present you my work about the neuroimaging of Down syndrome. So I hope that by the end of this talk, I convince you that the Down syndrome population is a very interesting population to study Alzheimer's disease, and also a very important one, because it's a core is of core importance for the medicine to study this population. So I will just start with a bit of epidemiology. I do have an issue with the... Is there a direction where I should... No. Puede ser que hay un on-off. Ahora sí. Genial. So I will start just a bit with a bit of epidemiology of Down syndrome. There's 1 person every 700 live birth that is born with Down syndrome. And at the moment, we consider that the population with Down syndrome is around 6 million persons worldwide, including 32,000 just in Spain. So this population has grown drastically over the last years. This is a graph that is showing the data for Southern Europe. And you can see that between 1950 until 1990, the population has almost tripled. And one of the main reasons for this is that we are now more and more able to treat these patients with their congenital heart defect. And we have been able to increase drastically their life expectancy. So these people are able to live longer, which explains that we have an increase in their population. Actually, we have done this study using the mortality data from the USA with Juan Fortea and Florencia Yulita, where we have looked at the age at death in this population. And basically here what you have indicated is the percentile for the population, for the age at death. And if we focus on the one of the median, the 50 percentile, we can see that in 1970, the people with Down syndrome were living less than 10 years as a median. And we have now reached they are now living more than 50 years as a median. So there has been a drastic increase in the life expectancy. And something that is also very interesting to look in this graph, and is the reason why we did this article, is that you can see that since 1990, the percentile 90 is quite stable. So the people do not live longer with Down syndrome. Like the people that used to live the 90 percentile of age of death has been quite stable. And you can see that all these different percentiles seems to plateau over the last decade, which indicate that something is capping, limiting the life expectancy in this population. This is actually something that you can see very clearly on this graph, where we see the population by age. So this is the total number of Down syndrome living in the US. And you see the evolution by age, the number of people by the different age. And you see that very little people with Down syndrome live above the age of 70 years. And this contrasts with what you will see in the general population, where obviously people live until 100, and there is around 25 years of difference. So why we have such a limitation in the life expectancy of the people with Down syndrome? because of Alzheimer's disease. So it's a population that is genetically determined to develop Alzheimer's disease. And this has become the major cause of death in adults with Down syndrome. So the reason why they develop Alzheimer's disease is because they have the triplication of the chromosome 21, which is associated with a lot of different genes that can increase the risk of Alzheimer's disease. But one risk that we think that is necessary and also sufficient to develop the disease is the presence of the triplication of the chromosome of the gene APP that causes for the amyloid protein precursor, and that will lead to an overproduction of the amyloid pathology. So as a consequence of this, the people with Down syndrome will present almost universally AD pathology at the age of 40, both diffuse plaque, neuritic plaque, and neurofibrillary tangles. You can see that they start to accumulate plaques between 10 and 20 years during their teenager years. And at the age of 40, they all have the full-blown pathology. So consequently, the cognitive symptoms and the clinical deterioration increase a lot with age. At the age of 40, we already start to see some patients that present prodromal Alzheimer's disease or Alzheimer's disease dementia. And this increase until at 60 years, there is almost virtually most individuals present a dementia at this age. We perform a meta-analysis to look at what was the average age at symptom onset in this population, and we observed that it was 53.8 years, so very young dementia. In this same work, we also look at the variability in the age of symptom onset across different studies in the world to see if it was difficult to diagnose this patient, if there was a lot of variability. And it was very interesting to see that the variability that we observe in the age of symptom onset in Down syndrome is actually the same that what you would observe in autosomal dominant Alzheimer's disease. And in several work of the memory unit in Sant Pau, led by Juan Fortea, we have also looked at the dynamic of the different biomarkers associated with Alzheimer's disease, and the dynamic of the change of this biomarker with the disease progress is very similar to what is observed in autosomal dominant AD. So if I kind of sum up this result, this is showing that Alzheimer's disease is inexorable in this population. We know that virtually all people will develop Alzheimer's disease, and this offers us an opportunity to look at the earliest stage of the disease. And we also know that Alzheimer's disease is predictable, at least as much as it can be in autosomal dominant AD. And we can therefore use metrics as in the field of autosomal dominant AD, like estimated years of onset, to look at continuous metric of the disease. And all this make that it is critical to study how Alzheimer's develop in this population so that we can propose them preventive strategy and treatment and determine some factors that can influence the evolution of the disease. So this is a work that we have been doing quite a lot in the memory unit. To give you an example, we have studied the effect of the ApoE4 allele on the natural history of Alzheimer's disease in Down syndrome. And we have been able that the ApoE4 allele does influence a bit the clinical presentation. The people tend to, the ApoE4 carriers tend to develop symptoms 2 years earlier. And we were also seeing an effect on the amyloid biomarkers and also on some neurodegeneration biomarkers. So this means that the ApoE4 allele, even in a genetically determined form of Alzheimer's disease, can impact the evolution of the disease. We also look at other factors very quickly, for instance, the effect of sex. There is a lot of discussion in the field of the general population and sporadic Alzheimer's disease on the effect of sex. And in the context of Down syndrome, we were not able to see any strong main effect of sex on Alzheimer's disease biomarker or even on the presentation. We did find some interaction with the ApoE4 allele with a worst effect of ApoE4, a more detrimental effect of ApoE4 in female, which fit very well with what has been found in the general population. But the overall picture did not show specific effect. So in the presentation of today, I will discuss more on my neuroimaging research line that aim at better characterizing the structural and the functional change associated with Alzheimer's disease in adults with Down syndrome. And I'm also very interested in the vascular pathology to try to understand at which moment in the disease process they emerge and how they can be related to Alzheimer's disease. So to do this work, we use the data from the DABNI cohort. which stands for the Dawn Alzheimer Barcelona Neuroimaging Initiative. It is a cohort that was started in 2012 to study Alzheimer's disease biomarker in adults with Down syndrome. And the recruitment is done through a population-based health plan run in Catalonia at the Alzheimer Down unit. Basically, all adults with Down syndrome from Catalonia are invited to benefit from an annual medical visit in our center with a neurological exam, neuropsychological exam, and a few other things. And they are invited also to participate to research, to accept that we use their data for research purpose. And they can also undergo additional exploration, for instance, undergo a lumbar puncture, blood extraction, have some genetic tests, the neuroimaging. We have also some sleep study, and we also invite the participant to give their brain in the future. So the cohort has grown a lot since 2012. We have a team that is doing an incredible job, and we have already recruited more than 1,135 adults with Down syndrome, which include more than 10,000 visits. So it's a lot of work. Regarding the neuroimaging part, we have at baseline 340 MRI, 100 CC6 FDG PET, more than 100 amyloid PET, and we are also starting to have more and more tau PET, especially with the PI tracer. So our participants are classified according to their clinical presentation. We have the participants that are asymptomatic for Alzheimer's disease, so they do not present any symptoms that can be associated with Alzheimer's disease. We have participants that are at the prodromal stage, so this will be the equivalent of the MCI stage, and participants at the Alzheimer's disease dementia stage that have both the cognitive and the functional impairment. You can also see that we have a certain group of participants that present uncertain symptomatology. It's participants that show some degree of cognitive impairment, but we cannot relate this impairment directly to Alzheimer's disease. So most of these participants, so this consensus is done by the neurologists and the neuropsychologists as a consensus. And most of the participants also have CSF and plasma biomarker. And for group comparison, we are also including participants from another cohort that we have in Sant Memory Unit, the SPIN cohort. And we have notably cognitively unimpaired individuals and also participants with sporadic Alzheimer's disease. So I will go straight to some results. So I will present you results that have been published or that study that we are currently writing. So first, I will speak about the structural alteration that we observe in the Down syndrome population. I've gone very quick on the introduction because I wanted to spend more time on our result. But to give you an idea, there is almost no study that characterizes the pattern of atrophy at the prodromal stage in Down syndrome. So the field is very green still. There has been several studies, but there is a lot of information that we are still missing about the natural development of the disease and how it can impact the neuroimaging. So in this work, we have tried to define what is the pattern of atrophy in the patient with Down syndrome. So here you have the comparison between the asymptomatic Down syndrome. So we know that they will develop the disease, but they have not yet symptoms, versus the prodromal. And you can observe a pattern of atrophy or volume loss that predominates in the temporal and parietal lobe, which is going to extend a lot at the dementia stage. And when we compare the patient with prodromal and dementia stage, we observe that the main difference occurs in the medial temporal and lateral temporal lobe. We also see a bit of difference in the posterior region. So we wanted to further explore the atrophy in this group, and we look at the frequency of brain atrophy independently of the clinical stage. So you have here how much a brain region, each line represents one region, and here is how frequent is this atrophy as compared to the haploid controls, so to the general population, and these are different thresholds. The important message of this slide is that if we set a typical threshold, we observe that the hippocampus is the region that is most frequently atrophied in adults with Down syndrome. It is then followed by the amygdala, the anterior cingulate, the superior temporal gyrus, and a group of temporoparietal region, like the posterior cingulate, the angular gyrus. So region that, for those that are familiar with Alzheimer's disease, are very known to be classically impacted. If we look at this frequency of atrophy, but this time in the different clinical group, we see that the hippocampus in the patient with dementia is atrophy in around 80% of the cases. We see also the same kind of order that I just presented. And something that is interesting is that we can appreciate on this graph the sequential involvement of the brain structure. In the prodromal stage, we also see this sequential, although at a lower extent. There are patients that have just the first symptoms, so we don't see a lot of extent on the atrophy. And when we look at the asymptomatic group, it's interesting. We see a bit of volume loss in the hippocampus and the amygdala, which kind of makes sense with the fact that this region are going to be eventually atrophied. But the surprising result was the anterior cingulate, which is not a region that you will typically find in when you think in the atrophy related to Alzheimer's disease. And we think that this may be a reflect of some structural abnormalities or specificities related to the development of Down syndrome. So this result point to us the specific vulnerability of the medial temporal lobe. We have seen that the hippocampus and the amygdala were especially affected. And to illustrate this, I have shown here some image of a patient at the asymptomatic stage on the top, patient at the prodromal, and a patient at the dementia stage. And I think we agree that you don't need to be a radiologist to appreciate that there is a clear loss inside of the medial temporal lobe. So we wanted to further quantify this, and we used the ASH-T1 that has been developed by UPenn to segment the different structure inside of the medial temporal lobe. So specifically, ASH allows you to segment the anterior and posterior hippocampus, the entorhinal cortex, the perirenal cortex, and also the parahippocampal gyrus. We have implemented in this study CRASH, which is a new a tool proposed by Paul Yukevich to reconstruct the surface for some of these structures. So we can obtain not only volume, but also cortical thickness for this region. So here, this graph is showing the integrity of this different region. In gray, you have the controls. In blue, the asymptomatic Down syndrome. In red, the prodromal, and in green, the demented. So there is a lot of results. So if I start by looking at if we start by looking at the comparison between the controls and the asymptomatic group, we observe two very interesting results. The first one is that we find a decreased integrity in the hippocampus, which is kind of what we have seen before, so make a lot of sense. But another interesting and surprising result is that we've observed that the thickness in the entorhinal cortex, in the parahippocampal gyrus, and Brodmann 35 is actually increased in comparison to the haploid group. And we also find the same result if we use the volume for this structure. So this was a surprising result. We were not expecting that they will have more than in the general population. When we look now at the effect of the disease stage, so the effect of Alzheimer's disease, we observe a kind of a gradual effect of the disease. The dementia stage was more impacted in all brain region, and the prodromal group presented significantly difference against the asymptomatic only in the hippocampus. So we wanted to go one step further, and we projected the evolution of this structure against estimated years of onset, which is here. So for the age 0, we are using the age of 53.8 years. That is the average age of symptom onset in the Down syndrome population. So the first observation that you can see here is that there is a nonlinear trajectory of the integrity of this structure over the time. You have first a plateau, or even in some region, a slight increase that is then followed by a decline in their integrity. And we have tried to quantify this, fitting some inflection point for each brain region. And what we observe is that the entorhinal cortex is the first structure to show a decline in adult with Down syndrome. And this occurs around 15 years before symptom onset. It is then followed by the posterior hippocampus and the Brodmann area 35, around 30 years before symptom onset. And then we have the anterior hippocampus and then the two other regions. Finally, in this study, we were also interested in looking whether the integrity of the medial temporal lobe can help us to predict symptoms. It's kind of a weird question because normally you don't need to predict symptoms. You have the neuropsychological and the neurological evaluation for this. But in the context of Down syndrome, because of the intellectual disability, sometimes it is a bit challenging to accurately predict the presence of symptoms. So the use of biomarkers can be a complement for the evaluation and can also provide some information in this regard. So we have put all our neuroimaging metrics in one statistical model together with the demographic and also with the CSF biomarkers of Alzheimer's disease. And we have performed a backwards stepwise regression and found that the best combination to explain the symptoms of Alzheimer's disease in this patient was to integrate the volume of the posterior hippocampus, age, CSF p-tau 181, and the cortical thickness of the parahippocampal cortex. And actually, this model performed very well. If we project it on the ROC curve, you can see that the model has an IUC of 96, which outperformed the CSF by their own, which have already a very good IUC. And you can see that neuroimaging by itself, the posterior hippocampus was the one performing the best with IUC of 86. So I will make a very quick summary of the result that we have seen so far. We have observed a pattern of atrophy associated to Alzheimer's disease in Down syndrome that resemble overall to the one that you will see in the general population. I have put here a work that Michel did some years ago, looking at the late MCI stage, and here a study comparing prodromal and dementia. And you can see that there is quite a lot of similarity between this profile, even though we could discuss if there are some subtle difference. We have also seen that it follows a stereotypical pattern of development, which include first the temporoparietal region and then spread into the rest of the cortex. And we have highlighted the specific vulnerability of the medial temporal lobe with change in the entorhinal cortex around 15 years before onset, symptom onset. And this estimation is very interesting because a different group from the US, from WashU, has observed that in Down syndrome, actually in the entorhinal cortex at around 15 years before symptom onset, you can start to see tau PET accumulating in this region. So these two events are likely to be associated one to another. And finally, we also observe some nonlinear change that could reflect some developmental specificity on one side, also some early Alzheimer's disease-related change like an increase in sickness related to the inflammation. We can discuss further this later on. So now I will move to the functional part. We have also looked at the FDG PET to try to understand how the pattern of hypometabolism was in this population. We observed that at the prodromal stage in the first graph, the hypometabolism predominates in the parietal structure, especially the posterior cingulate, in the medial and also the lateral, and involve a bit of temporal. And when you go at the dementia stage, it really encompassed most of the parietotemporal region and also include further frontal lobe. When we do the comparison between these two groups, what we observe is that what differentiates patients at the prodromal and dementia stage is really the hypometabolism in the parietotemporal region. So here again is a pattern that could remind us the one that is typically found in sporadic Alzheimer's disease. Maybe one subtle difference that we observe is that there is a bit more of hypometabolism. We have the impression inside of the basal ganglia and also the thalamus, which could be a bit of a specificity of this population. We have also performed the comparison against the control. These two results are very similar to what you have just seen. But I wanted to draw your attention on the comparison between control and asymptomatic Down syndrome. And here it was very striking to us because the literature was not kind of unclear whether there was an hypometabolism, an hypermetabolism, like results were unclear. And in our cohort, with quite a lot of patients, as you can see, we observe a very clear widespread hypometabolism in patients without symptoms. So this may be a specificity of Down syndrome that at baseline they present a lower metabolism than in the general population. But this pattern of hypometabolism is not neither fully random. It again involves regions that are kind of typically found in Alzheimer's disease. So we have to further explore whether this can be already associated with Alzheimer's disease or not. But it's a pattern that is beyond the anterior cingulate. The remaining of the pattern is quite similar to what you will observe in the clinical stage. Actually, you can see the similarity between this figure. We have also actually looked at the association, the interaction with age between the controls in blue and the red, the Down syndrome. And what we observe is that the hypometabolism in this temporoparietal region is much stronger, start much earlier in the Down syndrome. And actually at the age of 35, you can already differentiate the group for their metabolism in this structure. So here, 35, we're 15 years before the symptoms of onset. Finally, a last analysis that was interesting in this article is that we look at what could be the pathological correlate of the hypometabolism in this population, looking at association with CSF beta 4240, P181, the NFL. We found very strong association with all, but once we found all the biomarkers in the same model, the best pathological correlate was actually the NFL. And this makes a lot of sense because the NFL are also a biomarker of neurodegeneration as FDG-PET, and is also a biomarker of axonal loss, which we will expect to have a consequence on the pattern of hypometabolism. So we are following up now on this project and trying to compare the sensitivity and the sensitivity and the effect size of structural MRI versus FDG-PET. This is still quite preliminary, but our first results show that both modalities are similarly sensitive to detect the symptomatic stage. But when we look at the preclinical stage and try to detect the presence of amyloid, here structural MRI seems to perform much better than FDG-PET. This was kind of a surprise. I would have expect that we see some functional difference, but at the moment, our results indicate more that structural MRI outperform the FDG-PET for the preclinical stage. We have also looked at the MRI to see if we could have information about the function of the brain. We have looked specifically at a sequence that is called the ASL, that can give you information about the perfusion of the brain in a subset of participants. So here we have cognitively haploid, cognitively unimpaired, asymptomatic Down syndrome, symptomatic Down syndrome, and also symptomatic Alzheimer disease, sporadic Alzheimer disease. And what we observe is that in both groups, the symptomatic Down syndrome and the symptomatic Alzheimer disease, we observe significantly decreased perfusion as compared to the haploid controls. And if we look at the profile, we find again a pattern that is quite similar to what you will see with to what we have seen with the metabolism. We observe a hypoperfusion in the medial parietal structure at the asymptomatic stage. At the symptomatic stage, this hypoperfusion tends to expand into the lateral structure, parietal structure here, and also become stronger in the medial parietal lobe. And if we look at the pattern in sporadic Alzheimer disease, which is this figure, is kind of the same pattern, although the effects are much stronger. My hypothesis, but we didn't test it directly, is that is also in the sporadic Alzheimer disease, they may be combining the effect of age, which has a quite strong effect on perfusion, in addition to Alzheimer disease. And both could be altering and decreasing the perfusion. Actually, when you look at the effect size for both populations, you don't see a lot of difference. And when you perform the direct comparison between symptomatic Down syndrome and sporadic Alzheimer disease, we don't see any difference, or barely any difference. And you can see that the effect size is mostly blank, so showing that the pattern of hypoperfusion in both groups is highly similar. So this result kind of highlight that the ASL can be also an interesting modality to assess the function of the brain in this population and can be an early biomarker, as we were seeing some effect in the asymptomatic. I will now move with the vascular lesion, which is the last part of my talk. So beyond what I previously presented about the interest of Down syndrome, I think Down syndrome is also a fascinating population when you want to study the link between Alzheimer's disease and vascular pathology. And the reason for this is that they have a unique pattern profile of comorbidities and vascular risk factor. So on one side, they have a higher prevalence of obesity, sedentary lifestyle, or sleep apnea. But on the other side, they tend to have hypotension or normal tension, but they have rarely, almost never, hypertension. They have a lower prevalence of type 2 diabetes. They have no smoking habit or very little smoking habit, and they tend to not have metabolic syndrome. And when we look at the post-mortem data, we actually see that the Down syndrome population is protected from both atherosclerosis and arteriolosclerosis, which are small vessel disease. The arteriolosclerosis is a small vessel disease, which is typical in normal aging. And so this profile overall contrasts a lot with the one that you will typically see in aging, where hypertension is very frequent, where arteriolosclerosis is very frequent. And we think that by comparing these two different populations and the presence of vascular lesion in these two populations, we can better understand the interplay with Alzheimer's disease. So this was actually the project of my Miguel Servet, to study the neuroimaging spectrum of small vessel disease in people with Down syndrome and sporadic Alzheimer's disease, and to try to understand when this lesion emerge in the context of Alzheimer's disease, how do they interact with Alzheimer's disease, and what is their effect on cognition. So to give you some example of results that we obtain, for instance, you are seeing here the association with white matter hyperintensities and microbleeds, and the association with age. So these are two lesion, cerebrovascular pathology lesion. In yellow here you have the controls, and in the other colors is the Down syndrome, and this line represents the Down syndrome population. And what we observe for the white matter hyperintensity is that this lesion increase a lot more than in the Down syndrome, and the two groups are separated at year 44, which correspond to 10 years before the symptom onset. Similarly, for the microbleeds, we observe that this lesion increase in the 40s and go exponential with age, with almost one participant over two that presents some microbleeds at the age 60. This is way more than in the general population. You have here the control that we had for this study. We have also looked at the association with the clinical stage, and here too we observe that the lesion, this vascular lesion, increase with the vascular stage, with the clinical stage. In the asymptomatic group, there is no significant difference as compared to the general population, although some people start to show higher value. But after at the prodromal and dementia stage, there is a clear increase that you can also appreciate here for the microbleed. So this showed that in the Down syndrome population, you have Alzheimer's disease that is increasing drastically with age, but in parallel of this, also the different vascular lesion. These are association with CSF biomarkers. This is an example for the white matter hyperintensity, where we saw that there were strong association with biomarker of Alzheimer's disease, A-beta 4240, P2-181, NFL, and also biomarkers of inflammation such as GFAP and YKL40. And here again, we put everything in the same model to try to see if there is one biomarker that stands out. And the CSF NFL was again the stronger substrate of white matter hyperintensity, which was kind of expected. We would have maybe expected also that neuroinflammation could be more strongly associated, but NFL was the stronger one. We have also looked at the topography of these lesions. This is something interesting if you want to try to understand what can be their etiology, what is the reason of this lesion. If you look at the frequency of the white matter hyperintensity in the full Down syndrome population, we observe that it is mainly around the third ventricle, and it extends mainly in the posterior area, especially in the occipital and parietal structure. And this can be seen in this bull-eyes plot, where at the asymptomatic stage, the lesions are mainly circumscribed to the periventricular zone. And as you go to the prodromal and dementia stage, it extends to the juxtacortical structure, and it goes to more and more deep region. The topography of the microbleed is also very posterior. So here is the group, the control group. Here is the Down syndrome population, and we observe a lot of lesion in the parietal, occipital, posterior temporal, and also the cerebellum in the Down syndrome, which can be retrieved across the different clinical stage. And this is a result that really corresponds also to another work of the memory unit about cortical microinfarct that was led by Mateus Rosalem Arena and Juan Fortea, where they found that the cortical microinfarct in Down syndrome were also mainly located in the posterior region. So all these results, what do they suggest? What they tell us? They give us some indication on what could be the etiology of this lesion. We have different explanations. One that is quite obvious is cerebral amyloid angiopathy. So this is a small vessel disease that is associated with accumulation of amyloid pathology into the vessel. And this is more prevalent in the Down syndrome than in the general population. This CAA is quite frequent in Alzheimer disease in general. And in Down syndrome, it tends to be even more prevalent and to be even stronger. And this is clearly associated with a posterior dominant profile, a predominant posterior profile, and with the microbleeds. And the moment this pathology increase in the Down syndrome population correspond at the moment we're seeing the emergence of white matter hyperintensity and microbleeds too. There is other potential etiology for this lesion, notably for the white matter hyperintensity. They could be resulting from the Wallerian degeneration that will be secondary to the neurofibrillary tangles. They could be induced by the subtle hypoperfusion. And finally, a last hypothesis, which I think is kind of interesting, is that they could reflect neuroinflammation that could be driven by the trisomy, the triplication of chromosome 21, or by Alzheimer's disease and the vascular pathology. And actually, in a new study that we are currently completing, where we look at the longitudinal white matter hyperintensity, we observe that the white matter hyperintensity in the Down syndrome population, even though they were increasing across clinical stage, when you look at them longitudinally, they are not stable. And actually, so here is the evolution of the white matter hyperintensity across the age. In yellow is again the controls, in green and blue are the Down syndrome population. And this is once we have analyzed the white matter hyperintensity. So once we subtract the first and last visit. And what we observe is that in Down syndrome, rather than increasing over time, it is actually decreasing. So this was kind of surprising, totally not expected. So we started to think, it's because they have a certain degree of atrophy. We control for atrophy. It was not the case. So we thought maybe it's our quantification that is not good. So we asked to a neuroradiologist to evaluate each of the scan, being blind which one is the first, is the last. And he confirmed that there is more people with Down syndrome that regress than progress. You have also a bit of this profile in the controls. That is interesting. And so in our opinion, this white matter hyperintensity that are unstable, they may actually reflect the inflammation that is changing. Finally, last slide of result here. We are also looking at other biomarker of small vessel disease, for instance, the perivascular space in a collaboration with the University of Southern California and the PSMD, which is a matrix that is using the DTI, a different imaging modality. And we have actually first results that are super nice with this matrix. This is the association between the PSMD and the white matter hyperintensity. I didn't put the regression line, but overall there is already a good correlation. But we were quite surprised to see some people that show PSMD abnormalities without a lot of white matter hyperintensity. So we have like binarized the two metrics using different threshold and test plenty of threshold. And what we can consistently observe is that there is more people that show alteration in PSMD before showing any white matter hyperintensity than the opposite. So it's the comparison between these two. So it seems that a natural evolution of the impairment is to go first to PSMD plus, and then to also have the white matter hyperintensity. And this is interesting us because it would suggest that the PSMD may be an early indicator of cerebrovascular lesion. I will conclude now with the takeaway message. I hope I convince you that Down syndrome is a new population that should be more studied. There is actually one, if not the largest population that is genetically determined to develop Alzheimer's disease. It depends if you count the ApoE44 or not. But if we don't count the ApoE44, then the Down syndrome population is the largest population worldwide that is for sure going to develop the symptoms. So it's critical to better understand the development of the disease in this population, to understand what modulates it, so that they can have equitable access to treatment. And also, we are intimately convinced that it's not only that this population should be studied apart, but also by studying it, we can provide novel insight about Alzheimer's disease pathogenesis. There are patients that develop Alzheimer's disease at an earlier age, so we have less comorbidity, we have less copathologies, we have a different type of presentation, which can give us information about the disease process related to Alzheimer's disease. We have also, our study are also showing that the brain degeneration starts years before symptom onset. We have demonstrated the specific vulnerability of the medial temporal lobe and also the dysfunction, the early dysfunction in the parietal structure. And we are seeing topographical change that are quite similar to the one observed in the general population, even though there is some subtle difference that should be also considered. Finally, regarding the cerebrovascular lesion, we observed that they are associated with Alzheimer's disease symptoms and the biomarkers. They occur around 10 years before symptom onset, but we think they are not like an epiphenomena that are here by chance. I think we believe that they are tightly connected to the process related to Alzheimer's disease, to the overproduction of amyloid. And actually, in the different etiology that that are likely to account this pathology, is the CIEN that is associated with the overproduction of amyloid. And with this, I would like to thank all the memory unit, and especially the people from the Down syndrome unit that do an incredible job to do all this data together. I want to highlight specifically all the team members that contributed to the work that I presented: Sara Giardini, Alejandra Morcillo Nieto, Maria Franquesa Mullerat, Jose Arriola Infante, Ben Brunner, and also Juan Forte and Maria Carmona that are leading the Down syndrome cohort. And also a big thanks to our participant and the Fundación Catalana, and to you for listening at me.
Thank you so much, Alex, for this great presentation. I'm sure there are questions.
Oh, hi. Hi, thank you. Thank you very much. We in the brain bank we receive very few donations of Down syndrome patients, but from time to time we have some. Now the last one we had was well, maybe there's an anecdotal part of this question, and another part is not anecdotal. I think this brain had something that I had seen only once before. It was a very, very severe malrotation of the hippocampus.
Ah, yes.
And bilateral. And well, I learned at the time that is not very unusual in Down syndrome. And actually that is part, actually you show an MR in your case, just at the beginning. I think you have a series of magnetic with a case with dementia. You had an asymptomatic prodromal.
I'm almost there.
Dementia. Sorry about that.
Next one, here,
Yep.
here. Ah, it's out of my control now. Just here.
Yeah, that one, the lower row. That might be. Well, I cannot read it, but I mean that could be malrotated. Sometimes the malrotations are very mild. Sometimes are very. I mean the hippocampus axis is vertical, and well, I mean that is maybe an anecdotal. And one question is, if you see that with some frequency, how can you take that in mind? And more in a general aspect, actually the whole brain, the whole Down syndrome brain is a malformative brain. I mean, it's not brain structurally comparable to a non-Down syndrome brain. And I mean, in terms of volume of the hippocampus, volume of the cerebellum, and so on. How do you take that in mind when you analyze Down versus non-Down brains?
No, that's a great question. So for the malrotation of the hippocampus, is something that we have noticed, and we actually have one of our neuroradiologists that has a project on this. So he has done the visual rating of many scans, and he is starting to try to see what is the frequency of this malrotation, what is their clinical relevance, can we associate it with the symptomatology. So it's a work in progress. Yeah, this is something that we are exploring. As regard to how do we account for the specificity of the brain of the people with Down syndrome as compared to the general population. So we are doing this two ways. We are testing the quality of our pipeline, of our process to pre-process the image in this population. And overall, I should confess that our neuroimaging pipeline do very good job at the moment. Like for instance, this segmentation of the ASH, we have evaluated all of it, and it has never been like very not functioning. Overall, we are quite happy with the result, and we have not been unsatisfied. The other way to answer your question is that in all our study, we do two types of comparison. We have the comparison against the haploid population, which give us indication about what is the process in Down syndrome. But we're also doing a comparison within the spectrum of Down syndrome, using like the people without symptom related to Alzheimer's disease as the control for looking at the different stage. And this somehow allows us to account this. But for the pre-processing of the image is something that I would like to further dig and to try to see, to implement specific pipeline, taking into account the specificity of their brain, to see if I can improve or not, if there is a gain of doing this. But we have limited amount of time, so far I didn't do it, but is in my to-do list.
Great talk. Have you compared the FDG PET of Down syndrome with cognitively healthy carriers of AD mutations? I was wondering about this hypometabolism. Is this due to Down syndrome or have to do with Alzheimer in a hyper early stage?
This is a very good question. We didn't do it, and I think we should maybe ask data to Diane or to Raquel Sanchez, which also had FDG PET. I know that Washu and Boans is having some project where he's comparing the ABC cohort, which is one of the other large Down syndrome cohort of adults with Down syndrome in the US, with data from Diane. And I think the paper is not out, but I saw it at some conference, and they were not seeing like very big difference. I think that the autosomal dominant AD was more at the level of the general population, if I remember well, and the Down syndrome below. So it may be more related, at least partially, to other specificity related to the trisomy.
Very nice talk, Alex. I was wondering about your comparison between MRI and FDG-PET. You would agree that the result is quite impactful if you compare it to what we usually assume that is true in AD.
If we compare it to?
FDG-PET and it was, I think, in the later
it's just here. Yes?
Structural MRI, yes. So this result challenges a bit what we tend to assume, at least in sporadic AD, that hypometabolism, usually we assume that will be earlier. And I was wondering if this first maybe an effect of the size of the cohort. I think you had like 360 MRIs, but only 100 whatever PET. And also I was wondering if this is an effect of age. That is something that you mentioned in a different result, but I think one of the challenges of evaluating MRIs from AD patients is that actually AD-related atrophy is competing with general aging atrophy and also with much other diseases that may be also affecting the brain structure in older ages. And here you are actually analyzing a very young population that probably only has AD as the only source of atrophy, probably. And I don't know how you factor this, because I think this is a big factor on why we usually think FDG PET is better, is that the effects of FDG PET are much more selective to disease. So it's very easy to correct the effect of age, for example, and this is not the case for MRI.
Okay. Now, is that I had several answers, and then I feel I lost some. But the key, see, let's restart from what we know in the context of sporadic Alzheimer's disease. I'm not very sure. So let's be clear. When we compare asymptomatic to symptomatic, we observe similar sensitivity of both modalities. Both modalities are detecting a lot of difference. The difference are not present when we compare within the preclinical stage, the asymptomatic patient, those without amyloid to those with amyloid. So if you return to the studies in the general population and look at study in preclinical stage, amyloid positive versus amyloid negative in the absence of symptoms, I don't know if there is so many studies that demonstrate that FDG PET outperform MRI. You have one like this? Which cohort? Yeah, I didn't have it. And what was the result? FDG was performing better or both were finding difference? Okay, so I will have to revise this paper and give it a different test.
And then there are other cohorts like the Wisconsin Registry for AD Prevention, which is a very early middle-aged to older adult cohort enriched for AD risk. And they found the opposite. They didn't look at MRI, but they did look at FDG PET and found hyper metabolism.
The famous hyper.
Hyper. And then in the alpha cohort from BBRC, I think Gemma had this paper where they found an amyloid positive, tau negative, also hypermetabolism, which was related to GFAP levels.
Related to?
GFAP levels
And
CSF GFAP levels. So that is a possible correlate of microglia related glucose metabolism. And then at the A plus T plus still asymptomatic stage, hypermetabolism, this turned into hypermetabolism and the reverse relationship actually. So then they observed the expected. So there may be some nonlinear stuff going on in these very early phases of AD pathology, and depending if you're only amyloid positive or also tau positive. So I mean, Juan is obviously has done a lot of work with showing these kinds of nonlinear trajectories and initial increases in volume also, right?
correct.
Yeah.
As regard to, I got back to some element of your question. As regard to the different sample size, here is exactly the same people. So we have not different sample size. So it's all the people that have both modality that are included. So it should be 120. It's possible with the nonlinear tendency. I think that we should look more in detail with different papers that compare modalities. Possibly the prevalence of the tau pathology in addition to the amyloid can be impacting. Tell me.
And I'm just seeing that it's not necessarily all expected AD related regions that
That's
are
true.
showing these volume differences, like the occipital cortex, cuneus is there, and several frontal regions and insula, and hippocampus doesn't show up.
So yeah.
I don't have an answer, but it's certainly kind of unexpected results if you want to equal amyloid positivity as early AD pathology. So or early AD related atrophy. But that's good.
Yeah, you will expect more temporal atrophy, for instance, that you are not seeing a lot, and you're more seeing like frontal region. It's true. Good catch.
My hypothesis was that maybe this is very isolated, and in the more general population, it will be very difficult to separate this very small early AD effect from other atrophy components that may be very frequent in older populations.
Yeah, that's possible.
Also, the result of 50 years before onset is also very good compared to what we know from sporadic AD.
But is matching with what you know in terms of autosomal dominant Alzheimer's disease. They are finding kind of change around the same estimated years of onset.
Another question here.
Hello, thank you so much for the presentation. It was really insightful. I had a similar question to Jesus, so I'll ask another one. I was wondering what is the use now or the potential of anti-amyloid treatments in such a population, given that they have a high prevalence of microbleeds and thus an increased risk for ARIA? Like, what's the benefit risk ratio here and how is this handled in clinical trials? And if you can provide more information on that.
This is an excellent question. My disclosure, I'm not neurologist, so don't take what I'm saying as a I can give just 2 elements of answer and then Pascual can complete. So at the moment, I think that the Down syndrome population have been recommended to not be included, even though there's debate about this because there are population that we know they are going to develop Alzheimer's disease and you want to exclude them from the only treatment that exists to try to cure this disease. So it's very controversial and like in the Down syndrome community, the researcher about the Down syndrome population is kind of divided between people that want to be cautious and ask for specific clinical trial in this population, and others that assume that we should, by default, we should also apply the solution that are used for the other people in the general population. What is sure is that you made the finger on the right place in the sense that there is a big concern about the ARIA, because CA is one of the best predictor of ARIA, and they tend to have more microbleeds, and so this is the big concern. We are in Sant starting to have more and more clinical trial in this population, and let's see at the moment that this treatment become available in Spain, maybe in 2 years or something like this, if we can eventually have an option to treat this patient. Pascual, ¿quieres completar?
Yeah, I was going to say the same, that the only genetic Alzheimer disease is excluded is Down syndrome. The other genetic forms you're allowed to treat them. But with Down syndrome, because of the CIEN, they decided to exclude it in the US, I guess in
Yeah, very interesting discussion. I wanted to shift away from that and talk about the regional patterns, both for structural MRI and FDG PET that you were seeing. And I completely agree with your interpretation that they look pretty much AD-like, as you would expect them more. But yeah, maybe minor differences, but altogether you have these temporal-parietal, posterior temporal-parietal and posterior medial hypometabolism and the medial temporal and lateral temporal atrophy. Now, obviously these are group comparisons, so these are average maps. And in sporadic AD, the average maps look pretty much the same, but we know from looking at individual profiles, clustering analyses, that there on an individual level, there's a very high variability, and even attempts to cluster this variability in different subtypes of spatial distribution. As a genetically determined form, do you have any idea how the heterogeneity looks like in this population? Is it more constant, or do you still have?
So I think that the frequency result give us kind of a glance to this, and we can see that some regions are quite consistently impacted and atrophied in this population. Like in the AD group, we had 80% of the Down syndrome that had significant atrophy as compared to the general population. This being said, I think that the heterogeneity is something that has been still been totally understudied in the Down syndrome. Is really part of my next plan to look at whether we can identify, based on the pattern of volume loss, of hypometabolism, different subgroup. It was very interesting. Little time ago, we have published a single case of a patient with Down syndrome and a posterior cortical atrophy presentation. So atypical presentation with, and we had the toe imaging for this participant, a lot in the occipital. So really the atypical that you will see in sporadic Alzheimer's disease, but in the context of a genetically determined form of Alzheimer's disease. So this really go in your sense in that there is heterogeneity, and we want now to try to capture it. So we are going to this direction.
That's interesting for sure. Keep us updated.
What I think what made less visible maybe in Down syndrome population, this heterogeneity, is sometimes the difficulty to assess clinically the patient. So we cannot go make a clinical phenotype as as a strong clinical phenotype as we will do in the general population, because sometimes we are faced with patients at different degree of intellectual disability. The testing is not so easy. So we are sometimes limited in the spectrum of cognitive abilities that we can test, and things take a lot of time.
But
So
then again, the subtyping based on regional.
exactly. So the
So
neuroimaging
you
is
have
really
this
giving
limitation.
is going to be like a good way to figure this out.
If I may ask one last question,
Sure.
co-pathologies seem to be the big trend now in sporadic AD research. And I was wondering if there are any unique pathologies in Down syndrome associated AD that are more prevalent compared to others. I don't know, TDP-43 pathology or Lewy body pathology.
Yeah, super question. So we have the main co-pathology that exists in this population, and I think in the general population is the same, is the vascular pathology. And specifically here is CA that is highly prevalent. So this is due to the triplication of chromosome 21, the overproduction of amyloid, and the amyloid end up in the blood vessel. So I think that there is around 80% in autopsy studies that show some degree of CA. The other co-pathology that we start to study is the alpha-synuclein, which I think is found in around 20%. We just published a paper with the RT Quick, and I don't have on the top of my mind the estimate, but yeah, I think it's around 20%. Yeah, and I think some postmortem study that last Friday, it was last Thursday and Friday, was a specific conference in Barcelona about Down syndrome and autosomal dominant AD, and there were also some postmortem data, and I think the percentage of co-pathology with CA was around 20%. But it's very nice. This exact postmortem study showed that here again, pure Alzheimer's disease is the exception rather than the rule. I think it was 8% of cases with only pure AD. Yes. Depend how you treat vascular.
So I think we have to wrap it up here. Let's give Alex another hand. And thank you for your visit. Thank you.